Nose is pivotal in treatment of obstructive sleep apnea. We all know about it. And it is the static obstruction. It's present throughout the day, even in the night and day. But what are the things that we need to understand about the role of nose in obstructive sleep apnea? In the next 15 minutes, I'll try to cover that. So nose is the organ which offers more than 50% of the total respiratory resistance, the resistance which is carried to the last alveolus and to the diaphragm. The diaphragm has to put that much more effort on the breathing if the nose is blocked. What we also need to understand, a very simple concept, is that if the nose is blocked, the person has no choice but to breathe with the mouth open. When the mouth is open, the mandible goes down. The mandible goes down, the hyoid goes behind, because they are obviously a single mandibular hyoid complex. The hyoid goes behind. When the person is sleeping, the hyoid actually goes down. And where is the base of tongue attached? On hyoid. So we are also talking of simple anatomy. So when the hyoid is going down, the base of the tongue is also going down, and that means there is a retroglossal collapse. So nose is blocked, everything will fall like a domino. So don't ever think of treating obstructive sleep apnea without an open nose. It will not happen. So if I sound please, I need to sound please. Now see, this is the patient with the mouth open.
Mouth closed.
See, only with the mouth closed. Sleep apnea gone.
Mouth closed. Mouth closed.
Mouth open. So we understand that if we do not treat the nose, obviously the mouth will remain open and then the tongue will keep on falling back. It is most pronounced in certain cases, but to some degree it is there in almost every case. So even if you perform a good pharyngeal surgery, but you have not performed a good turbnoplasty, you have not performed a good septoplasty, even after performing septoplasty and turbnoplasty in the best possible manner, because the patient was a mouth breather since childhood, he persistently keeps on mouth breathing and his sleep apnea does not go away. So even if you have done the best surgery, you still have to train him to all these chin straps and all those things. You have to train, and you have to tell the patient well in front in the beginning that it will take 3 to 6 months for you to get used to nose breathing. That was concept number 1. The concept number 2 is whenever you are performing a multi-level surgery with a large tongue base. A small tongue base is absolutely not a problem, but the large tongue base, if you are doing nose, palate and tongue base all together, then definitely not try to be heroic. Stage it. Do the nose first. Second stage you can do the palate and base tongue. Why? Because ultimately you will require to put in the nasal tube for the base tongue surgery, as you just saw Sagar doing that. And a single stage nose and palate surgery is the commonest in my practice. But why? When the tongue base is not large. So multi-level surgery is commonest in my practice. Almost 80% of my patients I do the nose and palate together, because 90% of the patients require a nose job. So why to do two times? If the tongue base is not large in my dies, then I know that the extubation is not a problem, and I do it commonest. But even if I am doing a simple septoplasty and turbinoplasty in a low BMI patient, low AHI patient, but with a large base tongue, we are on toes, because this patient is going to give trouble while getting extubated. And I had almost lost a patient in my theatre. We had not anticipated. I am talking 10 years back when we were pretty new. So my anesthetist said nothing, BMI is 23, 24, AHI is also 20, 30s, don't worry. And we did only the nose job. And after extubation, the patient howling like this because his tongue was falling on the. So you have to understand. So there we realized that when we extubate those patients, we take out the tube, we put a LMA, and then let them completely come out of that. Tongue fall has to be controlled. So once you understand this concept, life will become much easier. This is concept number 2. Concept number 3, as we just showed, that you require a nasotracheal tube to operate on the tongue base. So a nasotracheal tube with proper laryngoscope, video laryngoscope, you can do intubation easily, and then you can perform a very, very simple, nice job on the base tongue. If you have already performed a tongue-based surgery, a large tongue-based surgery, you have to have this patient in the ICU for 24 hours if you have not done a tracheostomy. I'm talking of large muscular tongue bases. I'm not talking of simple lingual tonsillectomy like this. What was done, you can extubate on the patient on the table. But if you've done a large tongue base, then you must either do tracheostomy or keep the patient in the ICU for 24 hours. This is my take because I have suffered enough complications in my earlier years. So this is what I tell everybody to do. This makes your life much safer. You can actually see inside from the other nostril after 24 hours next morning peacefully. Patient is also awake, wide awake. You stop the sedation. When you see that your operated area is doing well, there is no bleeding, there is no edema, and then you can simply pull out the tongue. Even if you want to give CPAP, chalo, the patient is having a BMI of 40, you are not going to operate on the patient. But if you give CPAP, oral CPAP, the full face mask is not easily tolerated. It's very difficult to tolerate. But if you give a simple nasal pillow, it's much easier to tolerate. So you have to open up the nose, right? So how do we assess the nose? A CT scan is the minimum. Actually, in last 1 year, I have installed a CBCT in both my clinics. Why? Because the CT scan is the first thing that I need. So the patient has come to consult you, now you tell him, okay, you come with a CT scan, so another appointment. So you do a CT scan and you look at what? You have to look at the septum. Mild deviated septum is very important for sleep apnea. It's not less important because that it is not a sharp shot, but it's a mildly deviated septum, which is a high deviated septum. You have to correct it. Inferior turbinates, again, inferior turbinates, whether they are bony, whether they are soft tissue, you have to have a look at them. You have to look at concha bullosa. If it is not air-filled concha bullosa, but it is still a big bone, you still have to operate on it. Ethmoids, for postnasal drip, you have to perform ethmoidectomy. Ethmoids are there, and look at the nasopharynx. You will see a lot of adenoids even in adults. So these are the 5 things you must have a look at the CT scan. And typically a CT scan like this, you have to perform septoplasty. You have to reduce the left middle turbinate, both the bone and the soft tissue. You have to reduce the inferior turbinate, and you can see posterior end of the inferior turbinates are like polyps. You have to reduce them. You have to remove the adenoids. Adult, 90% block. Adult, you have to do all that because the airflow is like this, and you see the highest part of the airflow is in the area of the middle turbinate here. Can you see that? And the nasopharynx. These are the areas. This is how the airflow happens. So you cannot just do surgery along the floor and assume that it will work. You have to go high. This is how the airflow happens in the nose. So you have to be in that area. So if you see a high deviated septum, there is no timer. So excuse me if I exceed a few minutes because there is no timer. So the high deviated septum, turbinate hypertrophy, you have to treat everything. Now you see this patient was operated by somebody else, so there is a septal perforation. I am doing a revision. Now this high septal deviation, why was it not corrected? Because the person thought, this is point number 5, very, very important. Person thought that if I go high, I will go near the skull base. See, when you are in front of the middle turbinate, where is the question of seeing the skull base? This is not even the frontal sinus. When you go there, you will get the frontal sinus. You are below the T, frontal peak. The skull base will only start after the middle turbinate. You leave all those high deviated septums which keep on blocking your airway, and you think you have done a good job. So obviously, in my earlier years, 20 years back, I have left a lot of high deviated septums, but I now do a lot of revision correcting high deviated septums. So the point is that the skull base is absolutely nowhere nearby. Please go ahead, for my juniors, go ahead and remove the high deviated septum. It will give you a very good result. Now middle turbinate. If you have such a badly polypoidal middle turbinate, what help are you going to do by preserving it? If it is such a middle turbinate, if you just remove it, you will get a lot of space and nothing happens. It's completely a polypoidal middle turbinate. You remove it, nothing will happen, don't worry. Leave a stump for the identification and for all those twigs from the olfactory area to supply it. I'm not asking you to completely remove it, but also total remove it. Coming to inferior turbinate. So inferior turbinate we can mentally divide into 6 parts. Inferior turbinate is convex, so it has got anterior, middle and posterior part, and the upper part is almost, the upper part, I'll just show you the diagram. So if this is the anterior part, upper part is sinusoidal, like this. The middle part is bony, like this, convex, there is hardly any mucosa here. The last part is polypoidal. So you can outfracture the middle part, you'll get a great result. But the lower part of the turbinate is again almost always polypoidal. So if you remove the posterior and the lower part, leave the bone and the nerve supply and the blood supply, you will never get an empty nose syndrome, but your patient will be relieved of a postnasal drip, which is a persistent thing in presence of a clear sinuses. So if you do that, your results of septoplasty, turbinoplasty, sinus surgery will go through the roof. Lifelong the patient, I'll just try to show you now, that's the sinusoidal part. Lot of blood vessels, you can shrink it, you can touch it with a cautery, you can do whatever you want. Lower part is polypoidal. So upper part has got a lot of sinusoids, the lower part has got a lot of mucus cells which is secreting. So unless you have an 80-year-old, there will be, young patients will have a lot of secretions. The middle part is always convex, so just out fracture will get a lot of space. Because this is the area that you need for the air to flow, right? And then as you out fracture, see how much space is created. And then you just, I'm not showing any fancy thing, just take a microdebrider, remove the posterior and the inferior part. You will get such a large space. And this space, this actually does not even work with your nasal spray or Otrivin drops, nothing works on them. It's a constant source of irritation of postnasal drip. And then this part of bone you can either remove, you can do whatever you want. So I'm just trying to give you a glimpse of whatever you can do. Now see, you can create a lot of space. You can actually do channeling of this sinusoidal part. This is a revision of my own earlier performed surgery. So I'm again doing a channeling under local anesthesia. So you can do channeling, you can do radio frequency, you can do whatever. And this is another method of taking away the posterior polypoidal part, which I earlier showed with the microdebrider. So you use whatever equipment you want, but you have to achieve that kind of result. And if the bone is large, obviously you remove that part of the bone. Now I'm using a lot of sonopets. Let me come with numbers and the piezoelectric device, brilliant for the inferior turbinate. So you remove that, do a submucosal resection and remove the bone. And now see, middle turbinate was large, it has been trimmed. The inferior turbinate was quite big, it has been trimmed. No empty nose syndrome because we have preserved the bone, the nerve supply and the blood supply. And this patient's nose remains open for life. So this is the kind of result we can expect. Now, how to diagnose if a CT scan does not show ethmoiditis and it does not, the patient does not have an elevated IG? How the hell we diagnose, label the patient as allergic rhinitis patient and give a spray? This is a purely structural patient. There is no ethmoiditis, so there is no immune complex allergy. There is no serum IG which is elevated. So how we can diagnose this as allergic rhinitis? This patient was being treated for last 10 years by different ENT surgeons. CT scan was not done because his complaint was sneezing and watering. Simple septoplasty, turbinoplasty, concha excision, she's sleeping normally. Sneezing, watering has gone. Now if you have a patient who is having ethmoiditis all around, then this is a patient in making of a frank blown polyposis. So whether it is polyposis or whether it is patchy mucosal thickening in all the sinuses, do a complete surgery, do complete ethmoidectomy, and if you have to do a complete ethmoidectomy, because if you do not do that, the patient will persist with a postnasal drip. Postnasal drip is a very, very important cause of obstructive sleep apnea because the surface tension increases and the patient cannot take deep breath. So in those cases, give a good oral steroid because this is how you first clean up the honeybee nest before removing it, right? If it is a honeybee, you first give some dua, remove it, then you can do a good job. Similarly, give some oral steroid, your polyps will go away. Use navigation if it is available because then you'll be able to remove each and every small partition till the skull base and see the difference. See, this is the skull base and there's a stark difference in the color. If you do a complete job, the allergies will go down drastically. Your patient will never have to be operated again. Obviously, it will require a nasal spray. So this area, especially behind the frontal and between the frontal recess and between the frontal recess and the anterior frontal artery, we all leave work there. Why? Because we do not want to take chance. So use navigation. 3-4 of you can pull up and buy a navigation. It is required in the coming era for doing a complete job. So it will give you absolute peace of mind and you'll be able to do a complete job in every single case. So, and this concept of ethmoturbinectomy. So see, the middle and the superior turbinate, which are inflamed along with polyposis, are a part of the ethmoturbinal. Ethmoturbinals are the developmental units. First one is Agrawal, second is the middle turbinate, third is the superior turbinate, fourth is the supreme turbinate. But all ethmoturbinals are ethmoid in origin. So if there is polyposis, middle and the superior turbinates are from the same unit, so they will also give you trouble, little more, little less at times. Maxilloturbinal is obviously maxillar, therefore inferior turbinate does not develop polyposis. So with this, yeah, in 1 minute. So I think I'll not wait. If there is a septal turbinate, take care of that. Adult adenoids are pretty common. So adenoids are also seen in adults. Now see, this is almost a grade 3, grade 4 adenoid, and the person is actually a pilot. You can see the mustache. So obviously do a complete adenoidectomy. Salpingopharyngeal fold is our discovery, Indian discovery. Take care of the salpingopharyngeal fold, and this is the last slide. Tubal tonsils. My own revision, adenoidectomy done at a young age, patient comes with a frankly blown tubal tonsils. So take care of the tubal tonsils at the original adenoid surgery itself, otherwise they will come to haunt you. You can have a good pack. This is rapid rhino. With this you can actually do as much surgery on the nose as you want without any risk. Now this is a 13-year-old boy. As you remove the pack, we have done inferior turbnoplasty, we have done septoplasty, we have done adenoidectomy, we have done sinus surgery, everything on a 13-year-old boy, and you remove the pack without a drop of blood. Right? What else do you want? So there are devices which can help you to do a good job, and therefore you can definitely take care of the nose in the best possible manner in helping us sleep apnea patients. Thank you very much.
Thank you, Vikas. There's, I think, 3 questions which are similar. So I'll just mention one of them. There's an L strut of cartilage that needs to be reserved for high deviation when you're correcting it. What is the possibility of depression post-op? Depression.
Yeah, so if you take care of this, I think a very, very basic and very important question. Allow me 1 minute for this. So there are 2 points where you have this. One is anterior nasal spine. So when you open the cartilage of the septum, you try to rotate it, and this will rotate like this, the septal cartilage. So this point where it is rotating, that is the anterior nasal spine, and the upper part where it is just like a swivel. The upper point is the point where your septal cartilage joins with the upper lateral cartilage and the nasal septum. You call it keystone area. If you preserve these 2 points and remove the entire septum behind it, nothing is going to happen. Do it at any age group. Nothing is going to happen. So that answers the 2 questions. You just remain behind these 2 points.
I think one question was on the swell body, the role of nasal airway resistance with the swell body. The septal swell body.
Yeah, so if there is a septal swell body, you can just coagulate it. So because the moment you do good septoplasty, turbinoplasty, and even if you remove your middle turbinate, the septal swell body will try to come and block it. So a little bit of swelling is pretty physiological. If it is too much, then you can just do it. Otherwise, see, did you talk of upper airway resistance syndrome? No.
Okay, the third one is just a comment. This is on Dr. Yusuf from UK. He says that I address multi-level obstruction as I do the nasal and salpingo surgery and use Excite OSA for the tongue base, which works really well.
Yeah, so the first trial of Excite OSA in India we did, we are doing, I think for the last 4 or 5 months, I have given it to two patients. One, a young girl which was going to be operated. She had epiglottic collapse. She's doing 40-50% better. And the other patient is a doctor whom I have already performed from Dubai, orthopedic surgeon. So I have already done his palate. He had a tongue-based collapse before. He does not want to undergo a MMA. He's got a retrognathia, but he has also got a collapsible tongue. So I'm trying it on him. So Excite OSA seems to be a very, very good device. For those who do not know what is Excite OSA, it's a daytime
exercise,
muscle trainer. So you put it inside your mouth, it will give you excitement for 20 minutes. You use it for 1.5 months, the muscle will get trained and a little stronger so as not to fall.
Thank you.
Thank you very much.